So, Mike, let's turn the skin and the layers of tissue off for Dr. Dehghan, and let's talk about some anatomical considerations. So, Niloofar, when you think of these cases, what anatomy are you thinking about in your head as you go down the fixation path that you might be concerned about, and you certainly train your residents about intraoperatively?
Well, in terms of anatomy for femoral neck pinning, so typically that's cannulated screws. The
Hmm.
one anatomic thing is you don't want to be below the LT, below the lesser trochanter,
Okay,
or your start point where your screws go in. If you're below the LT, it increases stress riser risk of subtrochanteric femur fracture. So you want your screws to be at or above the LT. And then in terms of your orientation, the more vertical your screws are, the more stable it is. Sometimes you can't be too vertical because you miss the head.
right.
If you're too horizontal, then you're not getting as good biomechanics. So you have to find the best position where you're as vertical as can be, but still going along the neck. The first one, or the more inferior K wire or screw, you want it to be as low as possible, so as inferior as possible, to be hugging that calcar. On the AP and on the lateral, you want it to be center. And then the top two screws, again, we're doing parallel three cannulated screws. The top two screws, you want them to be center on the AP, and on the lateral, one's anterior, one posterior. So you're spreading because the femoral head, especially in an elderly person, it's like an empty eggshell.
Right.
You want to really grab the cortices and be hugging the cortices inferiorly, anteriorly, and posteriorly with those screws.